Last session of today on role of CT scan in growth of imaging. I request the presence of Dr. Gauraw Srivastava, Senior Consultant Radiologist, Medanta Medicity, who will be moderating this discussion. Dr. Srivastava, can we have you on stage, please? Thank you so much. Please, can we have a round of applause? Dr. Nitin Thorve, Chairman and Managing Director, Nidan Group of Companies. Can we request your presence? Thank you so much, sir. Audience, I think we can welcome our speakers with a little bit of warmth. Dr. Gaurav Kapoor, Associate Director in HOT Max Hospital. Welcome, sir. Dr. Vidit Gaur, Consultant Radiologist and Managing Director, Q Diagnostics. Welcome, sir. And Dr. Abhay Kapoor, Senior Consultant and Head of Unit, Rajiv Gandhi Cancer Institute and Research Center. Welcome, Dr. Kapoor. So over to you, Dr. Gauraw Srivastava, for taking the discussion forward.
Thank you, Elets, for welcoming us to this so much informative session. We've had wonderful sessions. We've been having wonderful sessions all through the day. Just now we experienced a wonderful session about the growth of ultrasound. So now we come to the next leg of imaging, and we are here to discuss the role of CT scan in the advent of imaging. And we have a very, very auspicious panelist sitting with us. We have seen the role of CT scan a lot and also change a lot over the last 40, 50 years. Ever since in the 50s and 60s, when it was just in a nascent state, and it started in 70s when we used to have only one detector. Now we have come to the stage when we are having multiple detectors. In 70s we had one source, now we have multiple sources. This gives a faster scan and a more clearer scan. Now of late we've been having so many apps which are as good as, virtual intelligence for AI, and they give outstanding results in all modalities, all parts of the body. We saw a huge role of CT scan in recent COVID pandemic. Almost every second patient was having severe pneumonitis or chest infection or chest congestion was going in for CT. And CT scoring, CT helped a lot in planning their eventual treatment and prognosis and treatment. So CT scan is now touching each and every part of the body, starting right from the head up to the toe. So I would now like to invite my auspicious panelists to give their opinion on this aspect of CT scan and the growth of CT scan over the last few years and the importance of CT scan in the community and public health. I will start with Dr. Nitin.
Hello, good evening, Dr. Thorve. See, I fully agree with you. There are lots of innovations from the technology perspective, right from the head scanner what we saw, then we got the conventional full body scanners, and then later on spiral CT scans, and then multi-slice, and now dual soap machines. And now there are even bedside mobile CT scanners. Then there are portable CT scanners, and even going ahead, portable means handheld CT scanners are not far away. That is what I recently discussed with the company peoples. So lots of innovations are definitely going on in respect to the machines, the technology, the spectral imaging, what we see, or even the use of this AI. Now, means for the patient safety perspective, there are lots of innovations means reduction in the dosage. Then with the dual sources also means whatever hazards what we are thinking of, they are taken care of. Then the split beam thing or thin beamlet sort of technology, which helps to minimize the dosage. So also, and this one means in every aspect, what we saw about PET scanners, then cancer detection, then the other things like means even the cardiac scanners. Cardiac scanners means really the tools are so useful. Means even the radiologists or even the clinicians. Many of the clinicians are not aware of the usage, and radiologist is the like people now just now like sir this sonologist told that we are not going to have our own OPDs, never will have. So we are not basically transforming the technology to the people's or means utilization of that is not getting increased actual utilization as per the available potential, because means I think that is not appropriately presented to the peoples how it is to be, because if you start some like putting forward to the peoples, then it is considered as you are marketing something. But really, like what we are observing and what we are using and what we are marketing in the social perspective, because the cardiac CT scanner, like the features, calcium scoring, it is really very useful tool, but people are ignoring the this one means actual the potential or the usability of that feature. Even means if there is like coronary angiography, again there will be controversy in the medical field itself. Like cardiologists will say that no, real time is really worth, and this is not like you can't rely on the this coronary angiogram. But the convenience of that and obviously the accuracy, it is there. So there are so many types of such features which are still ignored and are not appropriately presented to the peoples. But I can say there are lots of innovations, as sir said.
Wonderful. Very well said. So you practically, you said number one, you talked about the regular advent of technology that's been happening in this region. Second, you talked of radiation safety, how
Right.
the radiation dose has stopped. Third, you talked of timing. The scan timing has reduced so much.
Right.
I mean, likewise, we've seen a lot of water flow through the river in the last 50 days as far as CT scan is concerned. Now, I would like to bring in Dr. Vidit. Can you help us out with your observations about the advent of CT scan in imaging? Here you are.
Thank you, sir, for giving me the opportunity for talking about the topic. So, as we are discussing the role of CT scan in the, basically we are discussing the future, right? And we are also discussing the present things that are happening, but not they are not used as much, right? Like sir has clearly mentioned about the coronary CT scans. Personally, I have done it myself on me, right? Just as a preventive measure. And yeah, by God's grace, it was completely clean. But yeah, results were really very, as comparable to the real-time scan. Now we are moving towards the AI era. In the second wave of COVID, we have seen that a lot of people were, were going to the CT scan centers, getting themselves imaged. We were also seeing influx of a lot of patients. I honestly didn't know any AI company at that time who was working on HRCT specifically for the COVID people. But there was a point on one day we received a lot of patients. One patient even died on the CT table, unfortunately. And at that time, that struck me that had there been a software, right, just to assist me, just to assist the radiologist. We are also humans, right? So yes, the growth of imaging is gonna be like this only. We have to accept it. AI, just as a helping partner. Now second is trauma. Like trauma, hemorrhagic or ischemic. Even if this is cleared out at the AI level, like we have talked on DR and CR, that normal to abnormal. As a radiologist reporting CT scans, we just want only ischemic and hemorrhagic at the night time where the doctor might not be available. And this might work in the hilly areas, mountains. I don't know the name, but there is some doctor doing in Himachal that AI thing on the in the CT scan that are differentiating only ischemic and hemorrhagic, right? Now, moving to the very rural area sectors, as the sir has mentioned, we have 54 crore people in the very rural people. So CT scan definitely has a very good potential in diagnosing early tuberculosis, pulmonary problems, diagnosing even brain tumors. Low dose scanning systems should be there. So I think yes, there is a growth of imaging in the future, and we radiologists have to be a part of that. We have to accept every aspect of the things, technology also, machinery also, accessibility also. And definitely in the last, there should not be any conflict between cardiologists, gastroenterologists, radiologists, like it is better. No, the thing is, we are doing our part and we are doing it honestly. So CT scan is definitely helping us achieving the comparable results that surgeons and cardiologists are doing in the real time. Thank you, sir.
Brilliant. That was very well said. When you talked of rural and semi-rural areas, an idea comes to my mind is teleradiology. I mean, we can somehow, I mean, being Elets being a platform, all you Elets people, can I have your ears, please? Elets being a platform between the government and the private, government and the semi-private. So, I mean, teleradiology has a lot to do in this field. I mean, like this gentleman, Dr. Vidit, told about problems being faced in the rurals, or let's say delivery of services in rural and semi-rural areas. I mean, we can have CT scan machines there, no need to have a radiologist to be there. They can send the images by teleradiology, and the experts sitting here, we can report, and the rural person can benefit out of it. So these are ideas which we can pass to the policy makers, and that was very brilliantly pointed out by Dr. Vidit. Now I would like to handle the mic to Dr. Gaurav. Kindly speak about the advent of CT scan through the ages.
CT has evolved a lot during the past few decades, and I'd like to divide the growth reasons into two factors. One have been the technological innovations and advancements, and two have been the inherent advantages of CT as a modality. Now, the technological innovations have been already talked about, like increasing, slices, starting from a single slice, progressing to a 4, 16, and the latest, 256, 320 slice scanners, dual source scanners. Then has been, the evolution in the detector and the tube technology as well. The detectors have become bigger in size. The microelectronic circuitry leads to a generation of a sharper and much cleaner image. The tubes rotate, the gantry rotation times have reduced, they're much faster. Reconstruction algorithms, the iterative reconstruction algorithm which has come up in the latest, as part of the latest technology, leads to generation of a much clearer image with a reduced dosage. Then you have other development of other sequences like the metal artifact reduction sequence, which helps to generate a much clearer image in patients with metallic implants, stents, which is a huge boon, which is that used to be a limitation, streak artifacts from metallic, metallic implants. Then coming to the software part, even the workstations have advanced. You have AI applications being integrated into workstations, like GE's come up with a VCAR detection system for pulmonary, for efficient reporting of pulmonary nodules, a liver VCAR module for characterize segment lung liver segment morphological detail to help the radiologist generate a more efficient and an accurate report. The risk packs systems and the reporting systems have also evolved to make reporting friendlier, and as you rightly said, teleradiology that has enabled teleradiology and access to reporting where radiologists are not there. So that's one part. You know, all these technological innovations have led to, you know, imaging being more faster, quicker, generating more clearer image with a radiation, less radiation load. CT as a modality was always wonderful. You know, radiation was a challenge with CT. So that radiation doses have reduced drastically with the newer algorithms and technology. And with the faster, you know, latest machines giving you a much higher spatial, sub-millimeter spatial resolution, faster temporal resolution, you know, CT has expanded its clinical applications into many other areas, and the use in, even the routine use in usual areas is much frequented now. So the other part is, you know, the CT as a modality has its inherent advantages. It's a quick scan. You know, it's relatively cheaper than the other cross-sectional modality, the MR. There are more installations. It's more easier to train. The, you know, image interpretation is it's easier to train people interpreting CT images rather than MR images. So all this has actually contributed to you know, CT taking radiology and imaging just to a different level. Just a few examples, you know, in clinical practice. For example, recent advances in perfusion imaging have you know, revolutionized the imaging and interventions in stroke, especially where you're considering a mechanical thrombectomy. Then in CT has a large role to play in onco-imaging, you know, detection, characterization, staging, follow-up of tumors. Its integration with PET, integration with molecular imaging has taken onco-imaging to a completely different level now. CT-guided interventions have, you know, evolved, leading to, you know, diagnosis and therapeutics, role in therapeutics. So trauma, you know, trauma in emergency, CT is an extremely valuable modality. You could, you know, have the CT polytrauma protocol. You can actually scan the head, cervical spine, chest, abdomen with reconstructed images of the, you know, dorsal and lumbar spine in less than 10 seconds. I mean, less than 10 seconds, you could actually get a complete information about the entire, you know, body in cases of polytrauma. So, yeah, and as we've, you know, already talked, a recent example of COVID where CTs, you know, played a huge role in diagnosis, where RT-PCRs when the reports were available in 3 to 4 days. You had CT report in, you know, say a few minutes, 5 to 10 minutes. You could make a diagnosis, see which patient is sick, help in triaging of patients, prognostication of patients. So all in all, it's a wonderful modality, and I'm, you know, it's come this far, and I'm sure, you know, CT is poised for even greater growth and take radiology to even a higher level in coming years to come.
Brilliant. That was wonderful. Two takeaways from your talk that I took. One was the public health amalgamation of CT services, like that happened in the pandemic. The public benefited a lot from CT scoring. They benefited much better than a normal X-ray, than a CT. A CT provided a absolute concrete, staging of the disease, which helped in giving a perfect treatment for that. Second was your cost effectiveness. You said it is much cheaper than MRI. That is absolutely correct. In US, where MRI has become too expensive, the insurance companies have started not to pay in OPD MRIs. They have said that they will pay for only ultrasounds and some CTs. So they are patronizing USG ultrasound on a very big scale. They are asking their public to go for ultrasound for everything, and they are developing apps which can look at the ultrasound everything below the neck to your foot. The head cannot be obviously covered in ultrasound except for the eye. So you are very right, both ways, cost effectiveness and assimilation of CT scan in public health. I think these will come up big time in future. And fourthly, I have great pleasure in introducing Dr. Abhay Kapoor, Senior Consultant and Unit Head at Rajiv Gandhi Cancer Institute. I would like him to give his talk on the
Thank you so
scan.
much,
Yeah.
Dr. Gaurav. Actually, the advances in CT scan have helped the interventional radiology to a very large extent, and not only interventional radiology, but also to the patient. If you look at the earlier times, before a patient underwent renal transplant, he was sent to the cath lab for renal angiography. You had to tell the surgeon what is the size of the renal artery, whether there are any accessory renal arteries or not. But this has altogether stopped. The CT angiography is so good in its resolution and the multiplanar reconstruction that you do not need a catheter angiogram anymore. The patient does not need a femoral puncture just to know how many renal arteries and what is the size of the renal artery. So that's a big change which has happened. Not only in this sphere, but if I talk about other procedures done by the interventional radiology, CT has immensely helped us. In fact, if I look back at the old times, I really wonder how were people doing these interventions. Look at bronchial artery embolization. Today, without doing a CT bronchial artery mapping, I don't think most of the IRs are even willing to take the patient on table, although we may have to take it just in case of a severe emergency. But otherwise, the CT angiography is so good in its resolution that I do not do an autogram before trying to hook the bronchial artery. The CT angio itself tells me how many bronchial arteries are there and what is their exact location. It's not only the location of the bronchial artery. We all know patients who present with hemoptysis, the tumors or the patients with tuberculosis, the abnormal area has recruited blood supply from so many other aberrant arteries, be it from subclavian, thyrocervical trunk, or the intercostal arteries. This all is already clearly defined by the CT. So it makes the life of interventional radiologist very easy because you know what all branches you need to interrogate and directly go into them and start your embolization. This not only reduces the time, but also the amount of radiation exposure to the radiologist as well as to the patient. So without the recent advances in CT scan, I think our life would be very difficult. Now, if you look at other procedures like aortic stenting, in earlier days, maybe you were doing it in 2 steps. The first step just to define the anatomy and then order for the typical stent which would be placed in the patient. But now you don't need to do 2 angiograms. You do not need to break the procedure into 2 steps. With the CT, you already have all the exact dimensions. The stent has already been ordered, and in one single stage, you can carry out the diagnostic as well as the therapeutic procedure. Like Dr. Gaurav also mentioned about CT interventions. Well, the advances like CT fluoroscopy, they've really made a big change. In earlier days, when you had a single slice scanner or a 4-slice scanner, the time elapsed would be so much that it would be a nightmare in case you have to place fiducials in 4 places or maybe do celiac ganglion plexus block. You would inject and then come out, and the reconstruction would be so slow that it would take ages to carry out the procedure. But nowadays, if you are not really scared of too much of radiation, you can be present in the CT room itself with your radiation protection, put in your needle, and at the same time see where the contrast is flowing and complete the procedure within a few minutes. So that's a big advantage of the another advancement in CT scan. Another place where CT scan has really helped us is in carrying out amazing CT angiograms. If a patient with abdominal bleed comes to me, say a patient of pancreatitis, and there's a torrential bleed, there's fall in hemoglobin, but I would still, as far as possible, insist on a CT angiography before I take up the patient for catheter angiogram. Because in patients of pancreatitis, you do not know which artery is bleeding. It could be from hepatic artery, it could be from splenic artery, it could be from a branch of SMA. So it's a nightmare. If you have to go and hunt through all the branches, you'll end up using too much of contrast and too much of radiation for everybody in the cath lab. Now I'll give you an example. I had a patient for which we did do the CT angiogram, and mind you, the bleed was from left inferior phrenic artery. That's the last place that the IR would actually go in and hunt in a patient of pancreatitis. You would normally take a celiac angiogram, you would take SMA run, IMA run, and then be wondering as to what has happened. Should I do super selective catheterization and relook at all these branches? But CT angiograph had so beautifully already shown us that this is the particular branch which is abnormal, and we go ahead and embolize it. Similarly, for patients who have undergone renal biopsy. Though it's very straightforward, if the patient is bleeding or having hematuria, it has to be a renal branch, but still there are times when there are two branches which have been hit. One, which is intrarenal, and the second is the lumbar branch. So if the patient has been bleeding from the lumbar branch injury, you will, without a CT angiogram, if you do the catheter angiography, you will go ahead and embolize the renal artery which is bleeding, but you will ignore the lumbar artery because that's time consuming. You will not normally interrogate each and every lumbar artery, and the patient will still continue to have fall in hemoglobin. And then that would be the second step. You will ask for a CT angiogram, and the patient will have to undergo a second catheter angiography. So that's the major role which CT scan has played. But there is one advancement which has not been discussed as of now, that is DynaCT. That has changed the way we treat tumors altogether. DynaCT is something which happens within the cath lab. Your cath lab itself rotates around the patient, and while you're injecting, it gives you a CT scan. So this exactly defines the territory where the contrast is going to flow. Whether the tumor is getting its supply from this particular branch or not, this is what defines. So DynaCT is of immense help. It does not only help me be very super selective in my transarterial chemoembolizations, but also it plays a major role for transarterial radioembolization. In TEER, we really need to be very specific about how much of radioembolic material I am injecting into each branch. What is the territory which is being supplied? So the advances in the software of the DynaCT and CT also help me actually calculate the real time volume which the branch is supplying. Like I have hooked out the right anterior hepatic artery, and I can do the exact volumetry that this is the normal liver which is receiving the supply from right anterior, and this is the tumor volume. So that's how I divide and calculate what is the radioembolic dose which I have to inject, and that is what gives us the advantage and better results for tumor treatment. So these are some areas where the advances in CT scan have really helped the interventional radiologist, and I'm sure the progresses will continue and it will be a bigger help in the coming times. Thank you.
Fantastic, Dr. Abhay. That was great. I mean, talking of the assimilation of intervention, CT scan, and ultimately leading to the saving of a life. I mean, nothing can be better than that. Coming back to Dr. Nitin, can you talk of something which you would like to have in future which is not with us at present, as far as CT scan is concerned? Any software, any app, anything, just anything which you would like to make your life easy when you are on the CT console?
See, means regarding that, obviously, as everybody said, this new AI intervention in every field, means right from the, this one means from the radiographer's perspective, it will be obviously getting useful to radiographer. Then for the means obviously those softwares, AI-based softwares, to get more and more data, and then to radiologist to get the reporting easier. Means everywhere this AI is definitely going to help, but rather than means going for this one, means newer things, I would like to say that we should, means the point I am repeating from my last talk, like whatever the features are available, like just now sir said regarding this intervention. So really, do you think that the peoples are aware of the means usefulness of the this one intervention, like wherever, even in means therapeutic diagnostic usage, therapeutic usage, or prognostic usage? So whatever I have observed till date, means all those features, even clinicians are not aware of the usefulness of the things, and because of that, those features are very much underutilized. People are going with conventional treatment, conservative treatment, And really these features, this therapeutic features are giving magical results. Those are like means whatever are present now. So if we can utilize the features, whatever are there available with the present CT scanners or present research. So if we can, if we take an example of COVID, so initially we had gone through the Chinese this one literatures, and we had started diagnosing this one COVID through HRCTs. That time, I think in initial months in India, nobody was aware that this CT will be useful, and we were promoting. Why we were promoting? Because RT-PCR was like it was quite difficult to get RT-PCR done with lots of hassles and the timing and everything. And then people were getting scared of this municipal threats and everything. Like it was like means people used to be caught in some bad practices, and so that in that scare, though we were promoting that, but people were not using. But when like clinicians got that information and they start believing, then there was like means thousands of people in a queue for those type of CT scanners in that pandemic. So the utilization means, though it was like actually if we see the use of HRCT in COVID was majorly for prognostic purpose, but majority of the peoples were using it for diagnostic rather than going for that hassle procedure of RT-PCR. People were getting diagnosis through that, and then like whatever like measures of treatment were available for them in that particular geographical area. So they used to carry out further things over there. So means the basic point of telling all this is that I think regarding the present applications, even I will request this Elets platform to the experts like sir and even other peoples. So you should get the present features whatever are available for even therapeutic or even diagnostic purposes, and we should highlight those things to people which will be really useful. That is what I would like to say on this.
Wonderful. So what I gathered from your talk was that we need to have a very strong communication between ourselves, a clinician and the radiologist, and even with the public. As you rightly pointed out, when in the initial stages of COVID, when we were writing, or the clinician was writing CT scan of chest, people were taking it in a wrong manner. They were thinking, hey, some malpractice is going on. I'm just having a COVID and a running nose and cough and all. Why is he writing a CT scan, HRCT of thousands of rupees? So this finally people got to know, no, this was an essential thing. But in the initial days, this backfired a lot. They were cursing doctors, doctors are making money and this and that. So an effective communication with the public and the doctors. And second thing that you said, even among ourselves and the clinician, we should be abreast of whatever is going on. And I think Elets can play a very good role in this. This is a wonderful, I'm attending this thing for the first time, but I think I would love to attend it regularly. I mean, this is a wonderful initiative. Dr. Vidit, Dr. Gaurav, will you like to add something? Like one you said was brilliant idea, was that rural involvement. I like that a lot. Anything else you want to add?
Thank you, sir. So I would like to continue the thought of Dr. Nitin. So in a very big country like India, we, like Dr. Srivastava has said, that equipment was there, but we were not using that equipment, right? So here in India, we doctors are the equipments for the people, but people are not using us effectively, right? Like clinicians, doctors at PHCs, governments, they don't even know the significance of a very great modality like CT scan, right? It's very less time consuming, cost effective, right? And we can use it for a diagnosis. So as Dr. Nitin has said, that awareness is very less among the people, clinicians, doctors, and we as a radiologist, we know how to diagnose the people, but people are not coming in, they're not having faith. So the thing is, I think there is a need, like Kavita ma'am said about Sanrakshan. So there should also be some awareness programs regarding a good modality like CT scan, regardless of the dosing and all that is managed by us, that we will try to keep the minimal dose. But yes, some education is required in this sector, starting from the government hospitals, private clinics, hospitals, and also in a bigger platform, so that we can have a public-private partnership where the patients, for example, can be referred in government ambulances to the private diagnostic centers for getting a scan done and getting the diagnosis in the very relevant time, so that a proper treatment can be initiated even in the government sector, right? So it is a public-private partnership. And CT scan, role of CT scan in the growth of imaging, I think role of CT scan here can be a initiative by radiologists for the growth of imaging in the country as a whole, not just in the urban areas and affording people, right? Thank you.
So, ladies and gentlemen, I think we have talked quite, in a broad way about whatever developments that have happened in CT scan, how we have come all through those last 50 years in CT scan, where are we at present in 2022 as far as CT scan, right from the basics to interventional radiology is concerned. And we would like to thank all our panelists for giving brilliant and extremely good ideas to us. And I believe that comes to the end of our session. If anybody wants to. So I don't think we have any question, and should we call it, okay ma'am, yes ma'am.
Can we have a mic, Vivek?
Reduction of radiation in CT scan. We know low dose CT, but we so frequently do the angios, where the low dose angiogram, all these concepts are coming or getting applied.
I believe Dr. Abhay can answer that.
Yes, ma'am. Even low dose angiograms are available, especially if there's a pediatric patient. We do reduce the total amount of dosage which the child is going to receive. You very rightly pointed out one thing, which is about radiation concern. So this brings me to another important thing about providing the patient with the entire CT scan. What the current practice, whether it's a government setup or majority of the private setup, is we give films to the patient. But you have taken a few thousand images and you are just handing over a couple of hundred images to the patient. And ultimately when the patient changes hospital, or maybe if the patient is actually going for an intervention, say it's a patient of HCC who's ultimately coming to me from a different state for treatment, I will need to see the complete set of images and I will ask for the CD. But that CD is missing. So we will have to repeat the entire CT scan, which is a triple phase CT scan involving a whole lot of radiation. But we'll be forced to repeat it, because without that, I will have incomplete knowledge and the procedure will not be adequate. So maybe if Elets and the government and the private sector can get together and maybe make it mandatory for everyone, that anyone who's doing a CT scan has to mandatorily give the CD of the scan to the patient, it will be a big help for everyone, for all the patients. We will cut down on total amount of radiation, total cost which the patient undergoes immensely. So let's hope there will be some improvement in the coming years.
Regarding this point, I would like to add something like, as you rightly said, the useful, we are like whatever, we just go market driven, or whatever the practices are going on, we are following, or what people accept. So lay people feels, if they are carrying 4 or 5 films, they feel it's good, yeah, we have something, like we spend 5,000 or we spend 10,000 and we have a good bunch of films with me. But are those images really useful for the treatment perspective? As he said, no. Then you need more images, more comprehensive things, and those can be provided with a simple CD. But we all run behind the biohazardous material. We as a this one center owner or this one, we feel that those films, we know that those films are useless, that is the biohazardous material, unnecessarily we are spending that cost. We can, with a simple CD, everything can be solved. But with the push of people's or demand of the market, we couldn't do that. So again with this, like sir said, with this such type of platforms and our push, we should try to educate peoples and bring those good practices in the market.
Ma'am, I would like to add something.
Yeah.
Like in what I'm seeing in my daily routine, it's not necessary that to follow an angiography, you need to directly jump to another angiography. You can start from the basics. Suppose it's periphery, you can start from substitution by ultrasound Doppler. And if ultrasound Doppler is not able to give a conclusive diagnosis or any impression, then maybe you can go for a focus angiography. If you had some construction or reconstruction or ablation or obstruction which was relieved or thromboembolization in some part of the body, go for angiography for that part of the body and around 6 inches above that. No need to do entire whole body scanning. So there are ways how we can reduce angiography. Maybe Dr. Gaurav, you can
Yeah, about the radiation dose, you know, what has happened over the last few years, advances in technology and computing have led to development of newer reconstruction algorithms and, you know, predominantly the iterative reconstruction. What it does is it generates a much cleaner image, a sharper image with a much less radiation dose, which was not possible a few years earlier. So now if you do a routine CT of the chest, which has a radiation dose of about 7 millisieverts, you can do a low dose CT scan of the chest where you need a repeated chest scans in a CT, for example, a child with lymphoma who's being followed up, or in a patient of a lung who's on a lung cancer screening program with a radiation dose of 1.5 millisieverts. That's the reduction in dose you can have, and with a reasonably diagnostic quality images. Also, if you look at because of these advances, you know, a few years back, a CT coronary angiogram used to give a radiation dose of about 20 millisieverts, 25 millisieverts, which with the latest scanners has probably can go down to about 5 millisieverts if you have the latest reconstructive algorithms, the most higher, you use the latest technology. So that's has been the impact of technology on reducing the radiation dose in scanning.
And regarding CD scan, I mean the CD that has been provided, sometimes it comes to my mind that it should be from the same vendor or from some, it should be same, because most of the time the CDs are not DICOM friendly, they don't open in packs. Don't you find this is a problem? That if the patient comes with a CD also, they are not opening in our own packs or own DICOM system. That is a problem then. So
Yeah.
if it would be the same throughout, uniform throughout, so it would have been very easy for us to
Yes,
review.
ma'am. Yes, ma'am. What you are saying is right. Like we have many portals where we study the images, like Singo, we have PACS, we have Philips uses another software. For that, we have to moderate our systems at the IT level. Whichever institution we are working, the IT always has an access to these things. We have to pay a little fees, and those portals are opened. The fees has to be paid per year. So suppose a patient brings a CD which has been done on Singo, and we are working at a Philips center. So that can be seen. It's not that cannot be seen. The only thing is your center needs to be equipped with that software. I mean, thank you so much. And you've been wonderful speakers, and you've been even better audience. Thank you so much. Have a very good evening.
Thank you. Thank you to,
Thank you very much.
Thank you to all my esteemed panelists here, and may I request Dr. Ravi Gupta to please join us on stage and felicitate our panelists with a small token of appreciation for their presence here. Can we have the mementos on stage, please? Dr. Gauraw Srivastava, Senior Consultant Radiologist, Medanta Medicity, for wonderfully orchestrating this discussion. Thank you so much, sir, for your presence here. Dr. Nitin Thorve, Chairman and Managing Director, Nidan Group of Companies. Thank you so much, sir, for joining us. Dr. Gaurav Kapoor, Associate Director in HOD Max Hospital. Thank you so much, Dr. Kapoor, for being here with us this evening. Dr. Vidit Gaur, Consultant Radiologist and Managing Director, Q Diagnostics. Thank you. And Dr. Abhay Kapoor, Senior Consultant and Head of Unit, Rajiv Gandhi Cancer Institute and Research Center. Thank you so much, sirs. May I request you to have a group photograph along with the eHealth publication. eHealth magazine that's been catalyzing healthcare innovation since the year 2005.